All right, everybody, we want to welcome you back into the chat regarding ankle and foot injuries, and we want to welcome our physical therapists back in, Hanna and Jeff, to answer your questions. Guys, one of the first questions that we got asked was, what's the normal amount of time if you do injure your ankle and it's swollen, that it stays swollen before you should consider going to see a doctor? Hanna, if you want to answer that one.
Well, that is tricky. It does vary kind of person to person, swelling. And obviously, with the severity of the injury, that can vary as well. The foot and ankle is hard with getting the swelling out of that area because it's the furthest point from your body. So you may see as you increase your activity level or try to, the swelling actually fluctuates and you get some back, and then you ice and you elevate and the swelling goes back down again. So you may kind of see some fluctuations. It may take a good couple of weeks before the swelling completely resolves.
Okay. Dr. Ellington, you've joined us now. Talk to us about patients and swelling and what they should look for before they come to see you.
Yeah, sorry for being late. I just got out of the OR, so changed real quick. So swelling, is one of the most difficult things we have to deal with, and I tell patients when they have swelling, or when they have an injury, or if they have surgery, it's probably the last thing that's going to go away, and it's important to set that expectation up early. Because if they still have swelling at 3 or 4 months after an injury or surgery, they start getting concerned. So I think it's important to understand that it's normal, and it can be a year or more, honestly. And that and the problem with swelling is that it causes pain, and swelling causes stiffness, tightness. And when someone has that stiffness, tightness, that results in functional impairment. They have decreased range of motion of their extremity or joint that they're dealing with. And then when they go out and exert themselves, whether it's, sporting or recreation or just standing at work all day, that causes more swelling. And then it's this bad cycle. And the things that they should, look for before coming to see us is the swelling characteristics, what's it's related to, what helps it. You can do ACE wraps, compression stockings, anti-inflammatories, ice, and elevation are kind of the mainstays of treatment. And that's what we really lean heavily on, both the patient and therapy and training rooms to really help the patient deal with that swelling. Because oftentimes, I'll do a surgery on someone, fix a broken ankle or broken foot, and they, at 2-3 months, orthopedic standpoint, look great. The bones look great. The x-rays look great. And they're trying to get back at it. And the thing that really slows them down is the swelling. And so the training room and therapy is really critical in taking that patient to the next level and making them, go from a good outcome to a great outcome.
All right, we've got another question in the chat from Margaret asking about thoughts on athletes screened for orthotics as in some colleges. Do you think it helps prevent injury? Or should they wait to have an issue, Dr. Ellington?
There actually is a great study showing that custom orthotics can decrease the rate of stress fractures. I think there's some orthotics may or may not be perfect for everybody. Custom orthotics definitely are not cheap, but they do fit your foot specifically, and that there's some advantages there. But they have been demonstrated to decrease stress fractures, and that's really common in endurance athlete, runners. But we definitely see them in football players and tennis players as well that are after overtraining. The biggest problem with orthotics is shoe fit. And so for a lot of athletes, specifically soccer players, their feet or their hands, track and field, they argue about, a shoe, how many ounces it weighs. And so you put an orthotic in that, it can be a difficult problem to deal with. But I do think, and then so that's for the normal foot. And there are people out there that have a low arch foot or a high arch foot. And those patients, it probably does benefit them to have an orthotic to deal with their foot posture if they don't have a quote unquote normal foot.
Okay. A question for Jeff. When you see people with Achilles injuries, are they more susceptible to have that injury again in your experience?
It can happen that way for sure, especially if we don't take care of some of the underlying issues. Like, for instance, there's a lot of weakness in through that region, or there's an overstress through the area. They can easily re-injure it. It's not one of those things where it's a one and done sort of situation. So as long as we continue to build everything back up, the chance of a re-injury does decrease with that. That is one of those that can easily creep back in if we don't take care of the overall impairment correctly the first time.
Okay. Hannah, we've got a question about somebody, if you have any advice for dancers who practice point.
Any advice for dancers that practice point? Well, dancers in general are very flexible individuals. And we do see that they are in more of the ankle sprain population, and recurrent ankle sprains as well. So once they sprain it or stretch out those ligaments, we see that they continue to kind of roll that ankle and suffer continued instability. So my recommendation with them, if that's something that they're going through is instability, to look into bracing and stability of that ankle to control all of that motion that they have available. So getting on a good strength and stability program would be appropriate for them as well.
Okay. We've gotten a couple of questions about bunions in the chat. And Dr. Ellington, if you could talk about that in the treatment, it may not necessarily be in the realm of what we're talking about today, but, they should see an orthopedist and what your advice is for people that have them.
Yeah, Hannah and Jeff, you know the pain. So that's a loaded question. First of all, I tell people all the time, if your bunion doesn't bug you, it doesn't bug me, leave it alone. And so you want to avoid bunion surgery at all costs if you can. Now, granted, today I did 2 bunion surgeries, right? So, but those patients have often on our treatment, they've been through everything. So first, try to avoid surgery. Bunion surgery is very painful. That swelling issue that they were talking about earlier is very real in bunion and forefoot surgery. And so that's that. Number 2, athletes with bunions are a bad mix because we typically tell athletes that have a bunion to avoid bunion surgery until they're done with their career, whether that's high school, college, or professional, because it could be a lethal blow to an athlete if you have bunion correction. Not in all cases, but definitely want to be careful about that. And then, for anyone else, there are all kinds of bunions, and that means there's all kinds of surgeries. And so every single bunion, it sounds kind of dorky, but really does require a specific exam and X-rays, and then evaluation is really important on the foot posture, the patient's age, their activity level, their range of motion of their foot and their ankle, what they're looking at, what their expectations for bunion surgery is, and all those things go into like, okay, well then this particular patient gets this bunion surgery and this one gets that. So we at our academic meetings spend hours and hours talking about bunion surgery. It's pretty complicated, but it definitely takes a detailed approach. And if anyone's got a bunion problem, we'd be happy to take care of you and see you. Me and my partners all do them, and then when they get stiff and swollen afterwards, we send them to therapy.
All right. Who knew that bunions were so complicated? Hey, Jeff, do you have anything to add about that, about what patients can do maybe preventatively or to treat bunions that they have? Jeff, did you hear the question?
I did not hear the question. It was fading in and out.
Oh, okay. Do you have, in your experience, people with bunions, do you have any advice for them on preventative or things that they can do to help them feel better?
Unfortunately, there's not a whole lot of preventative stuff. Once it's there, it's kind of there. And then if it starts bothering, then we send them to Dr. Ellington. Our main focus at that point, though, is to try to, if there's a gait issue, so for instance, if they've started to modify their gait to come off of that irritated area, which can start causing other things up the chain further, that's really what we do so that we can try to prevent some of that. There are some things, a little bit of like a spacer every once in a while. Some people will come in with some wacky thing they found on the internet that sometimes might help them with it. But as far as an actual, once it's there in kind of our area, there's not much that we're going to do to make any sort of significant correction to it.
Okay. Dr. Ellington, another question for you about bone spurs. Somebody asked, they have them in their heel, sometimes inflames their Achilles. When do you recommend seeing a specialist about bone spurs?
Yeah, so if you have that bone spur in the back of the heel where the Achilles inserts, that has a specific name. We call it a Haglund's deformity. It's a common thing we see in 50s and 60s-year-old, but it definitely occurs in other people. In fact, I just operated on a professional basketball player a few weeks ago that had it. So, it's a wide range of age that can occur in, but it's a spur right on the back of the heel. Hold on one second. I keep my trusty model, for
that's outstanding.
So this is your foot, right? And then so your calf muscle's here, and it comes down and turns into your Achilles tendon, and your Achilles tendon inserts right here, and that little spur there can dig into the Achilles. And we always Achilles surgery is no joke, as Jeff was talking about a second ago, and it doesn't matter if you rupture it or if you have an Achilles spur, it's a big deal. And so every single patient we see with a spur on their Achilles, we tell them go to therapy and work on stretching, and not just twice a week did you go to therapy, but do it 10 times a day. We teach them some exercises to do in the clinic, and then the problem is everybody wants somebody to fix their problem, right? And this is one of those things that really focuses on therapy and stretching. The calf muscle is tight and it's pulling on that spur, it's not helping things. And so studies show that if you go to therapy, you listen to your therapist, you do what they tell you, you have an 80% chance of avoiding surgery. If that doesn't happen, what we do is we open up the back of and I did this case today as well. You make an incision on the back of the heel, you remove the Achilles tendon because the spur is on it, you shave it off, and then reattach the tendon. So you're basically effectively dealing with a tendon rupture rehab type protocol. And so we drill holes into the heel bone and we screw these anchors in that then reattach the tendon back to the bone. And then so I tell people all the time, I don't heal things, I fix things. So I fix it back to the bone. Now your body has to heal it, and it takes months and months and months for the tendon to grow right back into the bone, and then it takes months and months to get strong again. And so that's a very, very common procedure. It's one of the most common things we operate on every week.
It's very interesting. Hanna, a question for you. Do you have any tips for athletes that have very flat arches to help with their balance and speed?
Well, it just depends on if the flat foot is kind of structural or if it's flexible, meaning if it's fixed in that flat-footed position or if there's some strengthening that we could do to kind of recreate more of an arch. They may be a good candidate to see a professional, a specialist, and just get evaluated to see if they could take some orthotics too. But specific exercises, it'd be hard to demonstrate those right now, of course. But yeah, I would look into maybe orthotics, some kind of insert into their shoe to correct that flat-footedness.
Okay, great. Dr. Ellington, we were talking about bunions. Somebody asked about corns. So somebody that has corns on the bottom of their foot and it hurts, is there any treatment available?
So it just sounds kind of crazy, but a lot of forefoot driven problems, corns, bunions, hammer toes, pain over the forefoot are actually driven by a tight calf muscle. And so we go back to, people think that as surgeons, all we want to do is cut people, but it goes back to form meets function. And if your calf is tight, that results in functional problems. So a lot of times, it's crazy, but if you work on stretching and keeping your calf muscle and your arch flexible, and that's where we know every good surgeon knows that there's a good therapist behind them, right? And so that can really help. Second to that, simple debridement. We can, if you are in clinic, we can take a knife, a little scalpel, and we can shave the corn down. That could be a great temporary relief. And then occasionally the corn or the callus is actually caused by bony prominence. And if that's the case, then it takes a little more aggressive approach.
Okay. Jeff, a question for you about ankle braces. Are they helpful to help prevent ankle injuries?
Yes and no, in my experience. For instance, if you've had a fresh injury, they're really good at helping you stabilize as you're building the strength of that area back up. But once you get through that initial phase of actually needing it, they can become a little bit of a hindrance, because then it doesn't allow the muscles to do the job, and we start to rely more on that ankle brace versus our own natural ability to make those corrections. If, for instance, you did have a slight inversion movement, you're going to, oh, hey, the brace is there. And instead of letting our bodies take control of it, we're always relying on that outside force. But there is a place for them, and there's obviously, as long as they're not being overutilized, they're really good, which is sometimes what you run into when you see, every high school athlete, oh, hey, I got to go to the training room and get my ankle taped. It serves its purpose for sure.
Okay, terrific. And Hanna, a question for you. Somebody said their Achilles gets tight and tender and inflamed after they run. Is that normal? And if it isn't, should they see a doctor?
I wouldn't say it's necessarily normal, but I would ask more questions like how far are they running, type of shoe wear. So I think a specialist would be appropriate. That way they could have that conversation. But they could refer to the video earlier too, and just try some of the resistance band exercises and the stretches that we demonstrated, and see if those are helpful before going to a specialist if they'd like.
Okay. Guys, we're about out of time. One more question for Dr. Ellington. Is it safe to run barefooted?
Holy smokes. I don't know what the word is, tough enough to do that. This might be actually a better answer from Jeff and Hanna, but there's very interesting information and data out there, and there's a lot of anecdotal stories. I think I have barefoot runners. I'm sure they do too, and they swear by it. I would say it could be potentially safe if you do it the right way. And everyone that I know that did it, really, it's not just a slow progression. You have to understand your kits and your gait style and your mechanics, and I think really working with someone who knows about it, or maybe have experience and does it themselves, would be the best way to kind of approach that subject.
All right. Well, great information, you guys, and thank you for your time tonight. If you have any additional questions for our providers, of course, you can always call OrthoCarolina. And thanks for watching this edition of Inside the Training Room. Good night, everybody.
Good night. Thank you.
All right. Good job.